My name is Payam Nahid. I'm the Executive Director of the Institute for Global Health Sciences. Welcome to our first Grand Rounds at IGHS for 2026. Great to have you all back. I hope you had an opportunity for rest and restorative time with your family and friends. We are delighted to welcome Dr. John Rose this month as part of our IGHS Connect series, which, as you recall, every month has a theme, and this month is on workforce development. And I'm delighted that Dr. John Rose is going to be sharing his perspectives on how the global health workforce can be involved in evidence-based advocacy. Dr. Rose is an assistant professor of surgery with expertise in plastic and oncological reconstructive surgery. He's actually a long-time member of our community. Some of you know him very well. He's a former GloCal fellow, if I'm not mistaken. And he's now engaged in, I guess, paying back and mentoring and collaborating with Center for Health, Equity, Surgery, Anesthesia, CHESA. His work is dedicated to increasing access to safe surgery and preoperative care worldwide. So, at a time when we as global health professionals are navigating a very complex political environment, shifting policies and shifts in social and funding landscapes, this talk is excellent because it's reminding us of one of our responsibilities goes beyond just generating evidence, but rather pairing that with clear and effective advocacy to basically implement the evidence we generate into care. So please welcome me to, please join me in welcoming Dr. Rose for our first Grand Rounds of 2026. Thank you.
Thank you so much. This is in many ways coming home for me because I was a GloCal fellow a number of years ago, and in the slides I'll be presenting some of the projects that I did as far back as that, but also how they have a continuity with some of the people that I'm now mentoring through the CHESA program as well as the GloCal program. The title of the talk is Evidence-Based Advocacy because I think that right now we have to really rely on our academic strength of generating novel findings, generating research, but at the same time acknowledging the tumultuous times that we're in. And this painting is one of my favorites because it hints to two or multiple hats that we all wear as clinicians. One is to take care of the patient in front of us, which in this case appears as a lower extremity wound. But the other is to zoom out at the 50,000-foot view and really try to comprehend, wrap our heads around, and then ultimately even perhaps influence the 50,000-foot view. And that's where the health policy comes in. So I have no financial disclosures other than to acknowledge some of the funding agencies over the course of the years that have funded the work that I'm going to present. And just a little bit about myself. People often ask me, where did you get started or how did you get started in global health work in general? And this is me as, I think, a 4-year-old, the little porker there in the middle between my sisters. And I was born in Nashville, Tennessee, which isn't intrinsically a hub for global health work or global work in general, but we do have other things like college football, and I'm an avid fan of the Tennessee Volunteers. You'll find me on occasion sporting my hat during the season. But in terms of where it all got started, it's interesting to me that even as a youngster, if you flip over the hat, you'll find that not only is it the hat made in Bangladesh, but it's written in 3 different languages that it's made in Bangladesh. And I can't imagine people in France or Mexico or Spain who might care about the Tennessee Volunteers as much as I do, having been born in Nashville. But it speaks to the global nature of the world that we live in. And to me, it's not so much how did I decide to be globally minded, but I don't see any other way to be. Because we live in a globalized world where literally the hat that I wear on my head to a football game in the South of the United States comes from other places, made by other people, through connections that I didn't make that were curated and then kind of dumped to me in a local store. And without acknowledging those forces that are at play, you can't really influence them. So that's kind of where it all started. And then during medical school, I was at UC Irvine at the School of Medicine in what was called at the time the Program in Medical Education. It's since expanded. It was a pilot program then, but it expanded to all the UC sites. And it was founded by this gentleman here on screen right, who's standing next to me, Al Manetta, a gynecological oncologist of all people, a surgeon. And as a part of that program, the 5-year program, so it adds an extra year to medical school training, but we studied health policy, and we were able to engage with a number of different things. And part of the work that I did was working with community health workers. The screen left is showing us at a workshop in Chiapas, Mexico, where we kind of got into it in terms of the anatomy of the lungs to show the team and the health workers where the lungs are, where they lie, and how to auscultate appropriately. And then on the other end of that, we're consulting with the Ministry of Health in Nicaragua. And this is a picture from Managua, taken about a week and a half after the picture on the screen left. And this is where it first started to really cement into my mind the fact that we need to be able to think with different lenses and with different perspectives. Sometimes being on the ground, having boots on the ground, and sometimes stepping back and oscillating between those two to ensure that we're advocating in the appropriate spaces for the appropriate things. In terms of my surgical research and training, I was blessed to be able to continue to have this mindset. So this is a picture of me doing a bowel surgery at the Brigham and Women's Hospital in Boston with Adel Haider, one of my mentors, and it was our research group under his direction that led to the first collaboration formally between the National Institutes of Health in Bethesda and the American College of Surgeons. And the topic was disparities in care, consistent with the work that I was doing with the AHRQ at the time. At the same time, I was also able to engage with John Mira at Boston Children's Hospital, who's a longtime global surgery advocate. And he wears multiple hats as well, both as a researcher, as an administrator, but also as a clinician. This picture is from the Program in Global Surgery and Social Change group, taken in Dubai at the launch of the Lancet Commission on Global Surgery. And the picture on the right is he and I transitioning from business meetings into the operating room, back into business meetings, then back into the operating room, into clinical spaces, and we had to bunny suit up a couple of times. And so, again, reflective of the fact that as clinicians, we're oftentimes wearing two hats. And as a surgical researcher who's interested in advocacy and policy, one needs to be able to oscillate between those two spaces. At the same time, when I was a GLOCAL fellow, this is now dating myself a little bit, but more than 10 years ago, we'll just leave it at that, I was based in Mozambique, and we were working on a partnership between the National University there and some collaborators within the UC system. And at the same time, the Lancet Commission on Global Surgery was beginning to pick up momentum. And so as I was on the ground in Mozambique, I was also filling my head with ideas of how can this experience that I'm having on the ground influence some of the bigger policy recommendations that we're making as a part of the Lancet Commission. With that in mind, I want to tell the story of a patient. This is a patient from when I was in medical school. I took this picture of the trauma board. We often give fake names to patients who come in with significant emergencies. In this case, it was a young individual who had been involved in a border fence jumping incident where they had lost consciousness and came in with a deformity of the left ankle. These kinds of things are common in Southern California because of the border. And I discovered through these experiences of caring for these patients that there's some research that's been done to look at the height of the border fence and its correlation with trauma as it presents in Southern California at UC Irvine, UC San Diego. That correlation between what's clearly a social and political determinant of disease and the traumatic fractures that we were seeing in the emergency room and in the trauma bays was, one of those things that helped me to understand that there's more to surgical practice than just the scalpels and the operating room lights. Later, I was able to take care of patients as a reconstructive microsurgeon, and this is another one that I was able to see up here in San Francisco. This is a 29-year-old male who had an open metatarsal fracture dislocation, which is visible in the x-ray, also with a soft tissue injury after a jumping incident between Tijuana and San Diego. The patient underwent reduction, internal fixation, and then after that, plastics and reconstructive surgery was consulted for coverage of this wound, including the hardware. We were able to do so. This patient has what's called a radial forearm free flap, where we transplant tissue from the forearm down onto the foot to cover all that defect of soft tissue. and the patient recovered just fine. There are different ways that people talk about these kinds of presentations when there's so much social and political determinants involved in the presentation. Paul Farmer, the late Paul Farmer, would have described it as structural violence. Michael Foucault, a little farther back, would have called it biopower. Some of us in the public health community would call it vulnerable populations. But it's important moving forward that this is the premise for a lot of the work that I pursued as a GloCal fellow and also as a physician. So, in terms of an outline, I'll talk a little bit about global surgery and the current moment and how we got to where we are. Then I'll talk about a few projects where I really want to highlight some of my mentees who have been working through the CHESA program and the UC Global Health Institute to do a couple of projects here, based here while they're here at San Francisco, and then finalize with some key messages for evidence-based advocacy. The beginnings may be this, when Dr. Mahler, who was the Director General of the World Health Organization, stated that the vast majority of the world's population has no access whatsoever to skilled surgical care, and little is being done to find a solution. This was in 1980. Now, if you look at the response from academic surgery, or what was happening in academic surgery as it's measured through bibliographic analysis, you can see that going back as far as 1987, there was just kind of a rumbling of some conversation going on in the literature, and it was really after the turn of the Millennium Development Goals in 2000 that there was a sharp uptick. And this is when it really got interesting. Keep in mind the HIV epidemic. Oh, thank you so much. The HIV epidemic was raging during the 80s, 90s. Global surgery, for the most part, was not involved in most of that talk. The Millennium Development Goals, surgery was mostly not involved in that talk or that discussion. And it wasn't until after that we saw the first program dedicated to global surgery and anesthesia based at the WHO in 2005. It wasn't until then that we started to see involvement in things like the World Patient Safety Alliance in 2008. Those things all happen at the yellow arrow part of this curve. And then in 2015, it was really a banner year, because that's when the Disease Control Priorities Project, 3rd edition, published by the World Bank through the Gates Foundation, dedicated an entire volume, and it was the first one published, to essential surgery. This was a huge landmark for us in the global surgery and anesthesia community. The same year, the Lancet Commission on Global Surgery was launched, and I'll talk a little bit about that. And there was new policy going through the World Health Assembly. That year, 6815 was passed, a resolution that was explicitly dedicated to surgical, emergency, trauma, care, all the things that we talk about every day as surgeons. Because of these events, in 2015, there was a lot of recognition that kind of hit the billboards for the first time. For example, recognition of the disease burden. Deaths attributable to surgical conditions far outnumber the deaths resulting from HIV, tuberculosis, and malaria combined. We also found, through modeling exercises, that the global burden of disease study at the subcategory level involves surgical care in every disease subcategory, and we can map that now. And interestingly, it's not very surprising, that most of the need for surgical procedures rests in the non-communicable diseases area. We also found that with regards to access, 5 billion people at that time, which was roughly 70% of the population of the Earth, so that number is going to be larger now, lacked access to safe surgical care. We also understood that globally, disparities in workforce density were roughly 100-fold between countries of one region and another. Alarming. And we also started to understand the role of econometrics. And then we found that economic losses from surgical conditions would total $12.3 trillion lost between 2015 and 2030 in low and middle-income countries, which is as much as 2% of GDP in some countries. That's a huge number, huge. And in the same year, we got a strong endorsement from the World Bank. Jim Kim, president of the World Bank at the time, said surgery is an indivisible, indispensable part of healthcare. So at that time, we're feeling pretty great, and then this happened. And this happened to everybody. It happened to global health writ large. It didn't just happen to surgical providers. It didn't just happen to surgical patients. It happened to everybody, and it wrecked economies. It wrecked healthcare systems. And at that time, though, the way it affected surgery is that it caused what we call COVID lockdowns, which is where elective care was postponed or delayed while we were accommodating the surge of patients that was coming in with COVID. And the studies at the time showed that 14 million surgeries were canceled during 2-week surge periods across the world during 2020, which is a huge number, a huge number. And it wasn't until later that we found this concept of always-on healthcare. And from the commission within the WHO that evaluated this, they found that between 2020 and 2021, more people died globally from delays in routine healthcare than they did from COVID, which is a really bizarre thing to think about when we talk about COVID lockdowns and what it meant for people who have chronic diseases, people who have cancer, people who have diabetes, people who have congenital anomalies. And surgery falls in that category of things that were delayed. Because of that, part of our work with the DCP-4, which was just published online about 2 months ago, is to advocate for dual-purpose interventions. Dual-purpose interventions lie at the intersection between universal health coverage and pandemic response. And we have to rely on the understanding that they're not two separate spheres. They're actually ways to advocate for complementarity, and surgery lies within that space. For that reason, we felt that investments should target dual-purpose interventions that strengthen both of them simultaneously. And this is all now available in Volume 2 at the website there. And then this happened. And this, again, didn't happen to just surgeons. This happened to everyone who cares about public health, global health, healthcare, Medicaid. It's very far-reaching, and it's a little bit triggering to even see the picture. I have a hard time looking at it for more than just a few seconds. It's very troublesome that this picture isn't really just one person doing one thing. It's really a whole group of people who are moving away from the direction of social protection networks, who are moving away from mechanisms of patient safety, who are moving away from measures of population health, and who are ignoring in many ways the advocacy and the research that many of us produce. So it's a pretty big deal. And in terms of the current moment, we have to deal with now political uncertainty, reduced financing for healthcare and health, population health, misinformation campaigns, the resurgence of colonialism, I'm unhappy to say, armed conflicts, migration, and there's bizarrely an amnesia regarding health system resiliency and the importance that was on clear display during the COVID pandemic, only just a few years after the events. And one of the perspectives that really drives this all home is Atul Gawande's work. He was, of course, under the Biden administration directing USAID, which was dismantled just within weeks of him leaving his post when the new administration came in. He wrote about this in The New Yorker, gave an excellent talk about it to the Harvard Alumni Group, and then has produced a documentary here called Ravina's Choice that I recommend everyone view, where he's going around the world now and documenting what's happened because of this fallout. And I remember countless times operating with him and trying to pull nuggets of knowledge out of him because he's such a brilliant guy. And I was asking him, how do you start? How do you get going? And this was a long time ago. And I got a little flustered with my question at one point. He said, John, if you don't know what to do and you don't know where to start, just start counting things. And after you start counting things, you'll find that the things that you're counting don't really add up the way you think they should. And therein you will find some inspiration to go farther. And it was interesting to me to see that when it seemed like all was lost and everything was dismantled, everything was pulled apart and disintegrated, what he did is go out immediately and start counting things. Start counting what is the result of this withdrawal of support. And I think at a time when a lot of us are reeling, what do we do? What do we do? It's sometimes easier just to go back to the basics, back to the things that we do well. So having said all that, I'm going to talk about a couple projects. One of them is vital statistics in global surgery and anesthesia in the perioperative space, and the other is a project in a subspecialty area, which is transplantation. So in terms of the volume of surgery by country, this was released in 2008. It was the first time any of us had ever thought on a global scale about how surgery is delivered everywhere. Not just here, not just there, but all over the place. The problem with this publication in the Lancet is that 2/3 of the data was modeled. We don't love that. But it still shows a very interesting display of a spectrum of how often surgery is available for the people in this world. Of the 194 member countries here represented on the x-axis, most of the time people want to find the countries where they've worked or the countries where they live and say, well, where do I fall in this spectrum? You can see it goes from very low to very, very high. And some of the questions that come in a conversation about these data are, well, not only where am I or where is the place that I work, but where should we be? Are there countries that perform too few surgeries? The answer is, well, of course, probably yes. Are there countries that perform too many surgeries? The answer is also probably yes. So where's the sweet spot of where we should be shooting for? What's the target and what's the methodology that can guide us to that target in an empiric fashion? And then, of course, once we know where that target is, how do we upscale surgical services? How do we actually implement it? So therein is a research agenda, and therein is also an implementer's agenda of how we actually go from point A to point B. I decided at the time I was applying for my Glocal Fellowship to try to tackle both of those. And with regards to rates of surgical procedures, I wanted to understand at the population level, at a national level, what the rates of surgical procedures were. So I used the nationwide inpatient sample in 2010. We sampled, of course, the nationwide inpatient sample is a claims-based data set here in the United States that captures greater than 90% of inpatient encounters, and then it's stratified and it's accessible to all people who are willing to pay a small fee for it. And we categorized all of these encounters within the hospital system according to their inpatient primary hospital admission diagnosis. But we used the categories that were defined in the global burden of disease, and we queried how often those hospital admissions required surgery. A very simple premise. And what we found is from communicable to non-communicable to injuries, all of these disease subcategories required surgery at some proportion of the time. When we looked into psychiatric admissions, some proportion of the time also required surgery. When we looked at infectious disease-related tuberculosis, HIV, typhoid, many of these patients required surgery. When we looked at cancer admissions in non-communicable, many of them required surgery for port placements, biopsies, and sometimes even curative surgery. And this led us not only to publish it, but then to say, okay, well, how could we use this information then to translate it into some kind of policy-relevant benchmarking? And what we found immediately is that we needed to expand the previous definitions of quote-unquote surgical diseases, that there were not surgeries that always require, or there were not diseases that always require surgery and diseases that never require surgery. It wasn't black and white. In fact, it was a spectrum of gray. We also needed to think of surgery as an integral component of healthcare systems across many different phases of care. And then we also needed to model surgical need for populations. But we also realized that the U.S. is not a good proxy benchmark because it lies on the right side of that curve that I showed a moment ago. That is to say, the right-sided yellow arrow. But high-income countries where we have excellent data available trend down to where that other yellow arrow is, and that's where New Zealand is. We chose New Zealand as a benchmark country after looking at multiple countries because they have a far-reaching nationalized healthcare system, they have a centralized electronic database of clinical encounters, and they have excellent outcomes compared with their high-income country peers. So if they can achieve with a lower number of surgical procedures similar health outcomes at the population level, we thought, okay, that's a conservative way of modeling and benchmarking surgical procedure need. And when we repeated the same study essentially that I described from the United States with the national minimal data set in New Zealand, we found that the same thing was true. We found that across all of the disease subcategories of the global burden of disease, that that surgery was required some percentage of the time, some more than others, of course, but nevertheless present. So all of the same messaging applied. We published that, of course, and then we developed this notion of the disease-specific surgical incidence. So in each disease category, what's the volume of surgical procedures that's needed for the per volume of diseased person years? And then we used that as our metric. We then estimated the cumulative need for surgical procedures for countries all across the world based on that rate of surgical procedures and then the prevalence of diseases for each disease state of the global burden of disease. This was published in the lead-up of the Lancet Commission on Global Surgery in 2015, and what we found is that it was possible to match surgical procedure need to the epidemiologic footprint of each country on the earth. These are organized here according to the super regions of the GBD study, of which there are 21, but all the countries are represented here. And we can actually outline the differences of which types of surgical procedures might be needed in one country versus another country, and make very discrete recommendations. We also compared what need should be, according to our benchmarking, to what was actually being done. And we found that of the roughly 300 million surgical procedures that are being done each year, that's not enough. We actually need 143 million additional surgeries worldwide. We were also able to create country-specific targets of total and met and unmet surgical need because we have the information now from both sides. This is one that we performed for Mozambique that showed that the unmet need is 74% of all of their surgical procedure need, and the met need is only 26%. We were also able to use time trend analysis to look at how long it would take, based on our current rates of surgical procedures and rates of change, to reach the targets that were established as a part of the Lancet Commission on Global Surgery. For some of them, for some countries, it was actually well into the next century at the current rates of change. So this is some of the modeling work that we did to help maintain the momentum and continue to influence the advocacy that was being done. I mentioned previously that the World Health Assembly passed 6815 in 2015, and as a part of that, it's important to acknowledge that they recommended, in the language of this resolution, that measures of safe, emergency, and essential surgery anesthesia are needed for assessment and monitoring, and this was followed by 76.2 a few years later with a little bit more information about how to integrate it into perioperative mechanisms. The 6 indicators that were recommended by the Commission the same year, 2015, were access within 2 hours to a surgically capable facility, provider density, SAO, surgeon, anesthesiologist, and obstetrician, the surgical volume at a population level per 100,000, the perioperative mortality rate after surgery and during surgery, and then 2 measures of financial risk, impoverishing expenditure and catastrophic expenditure. And the question was, well, we can do all these fancy modeling exercises and benchmarking exercises for high-level advocacy, but how can we improve that other problem, the fact that 2/3 of that original data was modeled? That's going to require that we go to the ground level and build up data ecosystems. So we made modifications to the Lancet Commission on Global Surgery Metrics. This was called the Utstein Consensus. It convened 2 times over the course of almost 10 years. And the goal was to clarify many of the indicators with regards to risk adjustment, metadata, and data sourcing. And there are 2 publications now available that report on the highlights of those meetings. And from all of this work, it's also important to acknowledge that because of this momentum from the Lancet Commission on Global Surgery and the World Health Resolution, and also from the DCP3, that the core health indicators from the World Health Organization adopted some of these core metrics from the Lancet Commission. The World Bank did the same in their WDIs. So we considered this a win. We thought, hooray, we did it, mission accomplished, we're liberators, whatever you want to say. We did something here because we did a lot of modeling, we did a lot of high-level advocacy, we attended a lot of meetings in Geneva and DC, and bam, now it's part of their policy. Now things are going to change. And the next year, we went to the World Bank to chat with their data management team, and they had a site on their website that was dedicated to WDI for volume of surgery. And it said, no data is available at the world level. This hurt a little bit, I'm not going to lie, it hurt. It was just a hard moment. And as we were there at the bank, we exhaustively went through 2 hours of presentations and tried to highlight why it's important to collect these things. And what we realized, though, is that policy without boots on the ground is a moot point. You can pass as many policies as you want. You can have as many edicts as you want. But nothing's going to change without completing the cycle of what is the life cycle of data. challenge accepted. Challenge accepted. So I mentioned that as part of my GloCal fellowship, I decided to tackle both of these problems. How can we advocate at high levels with global data through modeling and benchmarking exercises, but how can we also improve data collection at the ground level? So I spent most of my time in Mozambique. Mozambique is situated in southeastern Africa, and I spent most of my time at 3 hospitals in the north, middle, and southern part of the country. And at that time, there were no centralized databases, still aren't. And there were inconsistent written records. And we had a fantastic research team. Some people in this room may know some of the people on these slides, but these are some of the people who mentored me as a trainee through this project, and I'll be forever indebted to them. Our research strategy was to use the Donabedian model of structures, processes, and outcomes of care. We used WHO situational analysis tool as a facility assessment tool to look at infrastructure, personnel, and equipment. With regards to processes, we reviewed 5 years of operative case logs within the hospital. We looked at their census, we looked at their protocols, we calculated Euclidean distance traveled. We did all of these things because we thought it would help us to get a picture, a snapshot of what's happening on the ground. We also created a prospective registry of nationwide and a nationwide cohort of surgical encounters. This is what we found, and I'll share these fairly quickly because I want to get through this to talk about some of the things we've done more recently. We found that there were, of the 3 pilot hospitals, there were missing processes and missing personnel and missing equipment and missing infrastructure across the boards. With regards to a census of operations, we found that there was a broad range of operations that surgical technicians, so not MD, not surgeons, but surgical technicians were performing at the district level. The most common was cesarean, most commonly emergency. And interestingly, if you looked at the 90%, the 10 most common procedures constituted 90% of all the procedure volume at these sites. With regards to a census of patients, we tracked patients as they came into the hospital and where they went in the hospital, and we found that 25% of all hospital admissions were to the surgical ward, and that 37% of patient days in the hospitals were also on the surgical ward, which was remarkable to us because if you asked at the time, what's the budget for surgical care in Mozambique, no one could tell you the answer. If you asked at the time, what was the budget at the hospital level, no one could tell you the answer. And yet it's a significant part of what the healthcare system is doing on a day-to-day basis at district hospitals and tertiary referral hospitals. With regards to distance traveled, we found that the surgical patients were the patients who were traveling the farthest to get care, indicating the greatest need. We also found in a survey of over 6,000 people that the prevalence of untreated surgical diseases was roughly 17% in a country which, by the way, has a guaranteed health care for all citizens. It's a nationalized healthcare system. We also launched a quality improvement data collection platform where using a phone or a tablet of some sort, you can easily input information from a patient record into a centralized repository. And we presented a lot of this information at the Lancet Commission on Global Surgery launch in 2015. And I'm going to highlight this guy right here. This is Machikani Kosa, who is one of our Mozambican colleagues. He's standing, of course, next to someone who needs no introduction in this forum. But Machikani Kosa went on to take the next level, which is to develop a national registry for all surgical encounters. And that was his GloCal fellowship. So we looked again at the Lancet Commission on Global Surgery indicators. We said, which ones can we gather from the 54 sites that perform surgery within all the provinces of Mozambique? And then we amalgamated them all by province, shown here. We found that annual case volume density fell well below the recommended target by the Commission of 5,000. And we also found that there was intra-country disparity between the capital city and essentially the rest of the country. We found the same thing with regards to the surgery, anesthesia, and obstetrician workforce density. And we found the same thing with regards to timely access. And then with regards to post-perioperative mortality, we found that there was also roughly a factor of 10 difference between the lowest perioperative mortality and the highest perioperative mortality. So numerous opportunities for the implementer to find areas to make incremental improvements. And we published this. And we thought, okay, great, mission accomplished, feasibility concern. Again, we're liberators, we did it. Congratulations, we made it. Pat on the back, high five. But then what we found is that having done it once wasn't enough. And I'm going to put a call out here, a shout out to Greta Davis, who's over here on the right of the audience, who gathered this data for us. And what we found is that if you look at nationwide reporting across the globe, 80 countries still have not reported, and this is as of just a year ago. And that less than 10 countries have actually reported their national surgical volume twice. This, of course, is a problem, because how can you measure incremental improvement? How can you measure whether something's getting better or worse in response to healthcare policy if you only measure it once? And what we found is that there was a shift away from publication in primary academic literature into the gray literature within ministry websites and other things like that. And this was published on the World Bank blog as well as in the World Journal of Surgery. And we decided to pose the question, how do we transition from one-off data sprints that were largely academic to sustainable reporting? And this information was presented in addition to these publications at the World Health Assembly last year at a side event. And again, thank you to Greta for taking this project on as a part of your CHESA fellowship. And then we enter another person, another CHESA fellow, whose name is Ismenia, who decided to tackle that next question of how do you go from a one-time, which is what Machikani Kosa did, to a sustained and integrated data gathering platform. And we decided to create a tool. We call it the S-Data tool, the surgical data tool, to accelerate the development of a national data ecosystem around surgical indicators. So this was presented at the IGHS 25 event, and I'll briefly summarize it here, but it involved convening a national stakeholder meeting in Mozambique, in the capital of Maputo, and we discussed indicators, metadata, IT, infrastructure, analytic tools, oversight, management, governance, everything you can imagine related to indicators. And we designed a survey tool that we would then use to go out to some representative hospitals and take essentially biopsies of metadata of what was being gathered. And what we found is that there was written data, there was electronic data, and then there were guidelines about data. And we, again, took biopsies of all of these things to see where the integrations were and where they were lacking. And what we found is that the data ecosystem in Mozambique, when mapped, generally flowed from individual facility reports to district reports and then to the Ministry of Health, but that there were multiple redundant pathways that were not necessarily overlapping or in communication with each other. For example, in the middle of this is all paper. On the left of this is electronic, the DHIS2 platform, the Demographic Health and Information System developed through Norway. And then there's also a surgical site initiative within the ministry that independently gathers data on how many surgical site infections there are. And then independent of all of those things, there's a manual of indicators, none of which are followed. None of them. Not in the DHIS2, not in the district reports, and not with the surgical site infections. And so there was a disintegration of the data ecosystem. And what we did is we created a tool, and it's near publication now, that can be used to chart for each of the Lancet Commission indicators that we monitor at a population level, how many of them are able to be calculated because you have the constituent parts that you need for the calculation. So for example, for perioperative mortality, you need how many people died and how many people had the surgery. For access, you need a denominator of the population from the census, things like that. And then we're publishing for each facility where we gathered these pilot data, whether or not their representative constituent data elements could be calculated into one of the commission indicators to identify where the weaknesses were within the data ecosystem. And with regards to translation into policy, not only has this been presented now in Uganda at the CHESA conference last year, or 2 years ago now, and also at the IGHS 25 event, but as recently as about a month ago, we also met with the Minister of Health in Mozambique and Maputo to discuss not only our findings, but also what we're going to do next. And in 2026, we're going to build on 2 technical working group meetings that we did in 2025 to launch what's called a National Plan for Surgery, Obstetric, and Anesthesia, or an ENSO. And we're very excited about that. So to be continued. With regards to surgical subspecialties, I'm going to bring this next gentleman into the picture, which is Alan. That's the only picture I have of him. So Alan, if you're listening, we need to do a little bit better on that. Alan has also been a research fellow over the previous 2 years. And his interest, of course, is in transplantation because that's the field he's going to enter. Currently, he's in general surgery residency. So we looked at the burden of chronic kidney disease, and we know that it's rising as a part of the tsunami of non-communicable diseases that's going across the world. The global prevalence is enormous, and even more interesting is that it's increasing. It's going up the list of leading causes of death, according to the global health estimates. With regards to chronic kidney disease, there are those who have the disease, and then there are those who advance to kidney failure. And then we talk about the people who, of those, have access to kidney replacement therapy. Most of the time, this is either in the form of dialysis or kidney transplantation. And there have been many calls to actions from 2010, the World Health Assembly, 2022, and then even more recently in 2024. But what we know right now is that there's a lot more of what's happening on the left here, which is dialysis, than there is what's happening on the right, the kidney transplantation. However, the 5-year survival for these patients is the opposite. It's 80% if you have a transplant and 35% if you get dialysis alone. So there's a gap. But there's not only a gap in practice, there's also a gap in knowledge, a gap in research. We didn't know, for example, the CKD mortality in its association with the dialysis rate at the country level. We also didn't know CKD mortality as it relates to the kidney transplantation rate. So we aimed to assess how chronic kidney disease mortality varies with national kidney replacement therapy rates in countries of all income levels. And this required data integration from multiple sources. We needed GDP per capita as a measure of socioeconomics, so to speak. We needed the chronic kidney disease prevalence. We needed the mortality. We also needed the kidney replacement therapy rates, so for dialysis and for kidney transplantation. And this came from a group of sources. We then assembled all of this data into corollary statistical models and ultimately with a generalized linear model where the outcome was for mortality, and our predictors are shown here. We found, to be very brief, that there was a relationship between the kidney transplantation rate and the GDP per capita, and we also found that there was a relationship between CKD mortality and GDP per capita. When we put these into the bigger model, we found that the association with GDP per capita was negative. That is to say, countries with a higher GDP per capita had a lower mortality. We also found that with regards to dialysis rate, there was no independent association with mortality. And we found that with regards to the kidney transplantation rate, there was an independent association with mortality. This is the first time that this had been shown. The kidney transplantation rate per GDP per capita is shown here. And then what we wondered is if every country in the world performed better than they currently do, how many lives could be saved? So we conducted essentially a counterfactual analysis. First, we wanted to see conservatively if each country performed as good as the best one within its rank according to World Bank income level. And then we wanted to see less conservatively, optimistically, if every country could perform at the level of the highest performing country, then how many lives would be saved. To do that, there's a little bit of mathematics here, I apologize, but we essentially take the model, use the base case, observed rates for kidney transplantation, and then create a counterfactual mortality rate that would be optimal according to what the model shows, and then see how many lives could be saved. And what we found is that using the conservative model, if each country performed as well as the best within its class, then you would save almost 300,000 lives per year, and well over 1 million if they performed as well as the highest performing country. This information was, of course, published, and I really want to shout out to Alan, who may or may not be listening today, given the fact that he has clinical duties as a surgical resident, but this was really a Herculean effort by him and the research team. So I want to go back now and focus on some key messages, which is that for me, reconstructive surgery is a bit of a metaphor. And at a time earlier in this talk when I referenced kind of the dismantling of a lot of the financial infrastructure through USAID and a lot of the programmatic infrastructure that supported, some of the thinking is the same in terms of what I think we need to do. This is a patient that I saw just a few years ago who had the green area, which is a sarcoma. The sarcoma had invaded his pelvis on the left, eaten away some of the bone. It had also extended outside the pelvis onto what is the left femur. It had also expanded upward towards the spine. So it required 5 different surgical teams just to get this cancer out. And regardless of whether or not you agree with what was done by Doge, one has to acknowledge that certainly they saw it as a cancer and they removed it. And that's where we are now. Surgically speaking, this patient went to the operating room and had this cancer resected by those 5 surgical teams. My job as a reconstructive surgeon was to evaluate the space after the tumor had been removed and look at all the constituent parts, the bone that could be salvaged and used as bone graft to support the pelvis and all the pelvic organs, the soft tissue that could be used to reline the floor of the pelvis, that could also be used to reline the skin from where the deficit was from the tumor being resected. And then in what they call spare part surgery, taking all these pieces, maintaining the vascular blood supply, and then refolding it and recreating the left side of this person's torso. And I think that we have to do similar things now in global health. We have to take assessment of what's been removed, what's been taken away, whether we agree with it or not. And we have to think of the things that remain and how we can repurpose, reuse, and continue doing the things that do work. I think we need to lean into interdisciplinary collaborations. This is a group of students here at IGHS. Thank you to Tracy for convening this group. And one of the things that we've started to do is bring together people from different disciplines, in this case surgery, public global health, and even economics, to start to tackle some of these big problems together. Another thing we have to do is lean into networks, societies, and groups of like-minded individuals. The picture on the top left is myself there with the Program in Global Surgery and Social Change group, where I started as a trainee, but this is from last year in Geneva at the World Health Assembly. The picture on the bottom left is myself with the World Bank group on the Disease Control Priorities Project. And then the picture on the right is myself with the DHIS2 coordinator from Norway, but then also with Machikani Kosa at one of the Utstein surgical metric group meetings. We really have to lean into those people who are like-minded so that we can develop strategies to affront some of the assaults that we've had. And then, of course, we need to lean into mentorship. I hope, if nothing else, this report that I feel like I'm giving back to the GloCal community and the Global Health Institute bleeds with mentorship, because I was the fortunate recipient of a lot of mentorship as a trainee, and now I'm in the fortunate position to be able to provide mentorship to others. And I'm going to close, yes, I think we have time. I'm going to close with just another clinical case. This is a patient that I treated just a few years ago here in San Francisco, a 24-year-old female who had a periosteal osteosarcoma, which is a really bad tumor of her left upper arm. It's a very large tumor, 18 centimeters. It involved the core of the bone, and it had essentially grown into the soft tissue around. It began in 2019, but the workup of the disease was disrupted by the pandemic in El Salvador, which led her to immigrate to the United States specifically to seek treatment. But she didn't do that until 2021, so there was a bit of a delay there. That's probably why it was so large. Her metastatic workup was negative, so we proceeded to surgery. She had the resection. This was done by the orthopedic surgeons. And they left essentially these 2 stumps of bone, both proximally and distally, within the arm. And this is a 15-centimeter ruler showing how large the tumor was, with both soft tissue components as well as bone. And this is the reconstruction through what's called a Kapana technique, where we take an allograft tibia from someone else and her own fibula, which I harvested from her leg, and we transplant that up into her arm and reconnect it with vascular anastomoses in the arm. We then close the wound and we watch her progress. She did very well postoperatively. These pictures are from roughly 6 weeks after her surgery. Not only had she healed her external wounds, which is shown on the left, but she had also maintained function of all of her joints, which demonstrates that all of her nerves and vascularity were preserved, which is, again, an outstanding result. She's able to open her hand, close her hand, extend her fingers, stretch her fingers, and of course, flex her elbow. Her fibula donor side is shown there on the right. She healed that as well. So again, we thought this is amazing. Mission accomplished. Slam dunk. This is an example of what you can accomplish if you extricate a person from a bad scenario and put them in a place where they have access to all the care that they need. But she's an immigrant to the country, does not have legal status, and she struggled to follow up with physical therapy. She ultimately could not comply or adhere to the adjunctive treatments like chemotherapy. She presented 3 months later with hemoptysis, which is bloody sputum. She had disseminated cancer, and she died 3 months later. And so it went from this huge success story to actually a reality check that UCSF isn't enough. Excellent clinical care isn't enough. There are social and political factors that are so strong, the structural violence is so embedded, that it's impossible to overcome it with a scalpel. And I find that densely humbling. The premise then, to end on a little bit of a brighter note, is that if medicine is to fulfill her greatest task, then she must enter the political and social life. Do we not always find the disease of the populace traceable to defects in society? So since disease so often results from poverty, physicians are the natural attorneys of the poor. What Virchow was trying to do here was to lull the physicians away from the bedside just a little bit, to acknowledge the limitations that we have in being able to cure disease if we don't engage in the bigger picture. And I want to close with that. Thank you.
Thank you, John. That was an incredible presentation. Thank you. We have just a few minutes. I think we could take maybe a question or two from the audience. Yeah, George.
Thank you very much. That was, sorry?
Do we have a mic just to
Oh, yeah.
people online? Yeah, thank you. Just flip it up.
Thank you very much. That was quite inspirational. I'll tell you a story about my operating, being called in to assist in Mozambique in 1984.
Oh, wow.
Yeah, some pretty scary stuff. Anyway, so I'm an epidemiologist, even though I play a doctor on TV. You know, it's when you present rates of surgery in developed countries, you're looking only at inpatients. There's a huge amount of outpatient surgery, especially if you count dental surgery. How does that change all this around?
That's a fantastic question. So one of the reasons that I didn't disclose that we chose New Zealand was that the highest rate of surgical procedure was actually in the oral surgery area, because they do most of their extractions and evacuations of abscesses in the operating room in a hospital. So they were included. However, you bring up an excellent point about outpatient surgery. In other countries that we surveyed, this one included, roughly 50% of national volume of surgery is in the outpatient setting. The reason we didn't include it in the modeling because was in part methodological, which is a longer conversation, but we were also trying to err on a very conservative estimate, and so that's why we chose to do it that way. But you bring up an excellent point, and I'm going to also throw in another plug for Greta Davis here, who has taken that challenge on as a part of her CHESA fellowship, and she's working on it right now. So what she's doing is going back through some of those modeling exercises, adding more detail, adding costs as well, and using both inpatient and outpatient data.
John, I'm going to maybe take the privilege of asking the last question. You know, you and your team's colleagues abroad are working so diligently to gather the data, the evidence, presumably to put in front of policy decision makers. And we know intuitively, I mean, you ask anybody, that surgical unmet need is something that should be filled. In your opinion, who gains the benefit from delaying, from investing in scaling up surgical capabilities worldwide? What is Why is the financing and the political will lethargic, in your opinion?
It's a great question. So there are multiple forces at play. Part of it is just inertia. Part of it is just cultural in terms of the things that we think are priorities. Some of it is colonial in terms of the past that global health shares with regards to its deeply, deeply rooted ties to infectious disease and concern about contamination from the other, the anthropological other. But those things aside, it's also difficult for budgeteers, for the bean counters out there, to understand how expensive an operating room might be in comparison to other platforms of care. And part of the task that we have in front of us now is to demonstrate not only that surgery is clinically efficacious in treating a disease, but also that it is budget neutral, or that it may even add value to a population's health and GDP by returning people to the workforce. And that's part of what we were meeting in that picture with the health economists group about, is to improve that argument as we try to assert the value of surgery and anesthesia care.
I know we're over time. I just really wanted to thank John for an incredible talk. I can't shout as loud as George, but other people online. Okay, if you can hear me, thanks for, really presenting like 15 years, an odyssey of work. And I think what really comes through, the mentorship that you provide to so many folks in the room. Sam is here, one of our PhD students from Ethiopia, who's a pediatric surgeon. Emmanuel, who's a pediatric surgeon from Uganda, is here doing clinical training. Greta, who's a plastic surgery resident, has done a ton of work. Tracy, thank you for expanding the circle and pushing us to all talk. But how deeply we all care about this, I think, from the patient level to making sure that our data works. And I know that with the experience in this room and the history we have with what has happened here, is that we have the ingredients to put the mess together to find some solutions, because it is a messy time, and we have the methods and we know what works, and we just have to push really hard. And I'm just really thankful for you leading this charge, but also to everyone in the room. We can do this and pick up the mess of what's left behind, and make the world better and fairer. So, and maybe a little cliche, but I just wanted to say thanks. Yeah.